Welcome to the huddle. Our topic today is new tools, new timing, smarter prevention, the evolving heart guidelines. And I've got a story to share before we get started. Dr. Molina and I have been looking at this guidelines and thinking through how to present these guidelines to you. And through all of that discussion, we've had many um, discussions around, what works, what doesn't work, what is the science behind all of that. But I have mentioned to Dr. Molina several times to make sure that he does talk about the smarter prevention piece of the guidelines. So hopefully we'll hear about that from him. We are also very, very pleased to kind of bring this presentation to you in collaboration with IIT Bay Area alumni. So thank you for being partners in this and for participating in these health talks. The South Asian Heart Center is celebrating in 2026.
I'm going to be on a huddle. I'm going to be giving a lecture.
The 20th anniversary. We started in 2006. So it's come a long way since then. But the key thing to celebrate today is that as we celebrate the 20th anniversary, the 11 institutions that have come up with the guidelines have now agreed with what we have been doing all of these years. And so that's a real validation of the work, not only in just the evaluation of heart disease, but actually in terms of prevention and reduction of risk, which we are very proud of as well. For the first time, the guidelines now talk about lifestyle as a prescription, not just a suggestion. For those who are new to these huddles, I just wanted to mention that the South Asian Heart Center is a nonprofit organization, and we are funded through grants from El Camino Health and El Camino Health District, and as well as community support through donations from community members, just like all of you. El Camino Health has made an amazing amount of investment in the South Asian Heart Center, but with it, the message that the South Asian Heart Center community is important to El Camino Health because it's part of this big and growing community here in the Bay Area. And that is one of the reasons why it has actually brought together the South Asian Heart Center to the community. The South Asian Heart Center has had a lot of successes along those 20 years, but we are proud to indicate that we have 3 very, very key prevention programs. Aim to Prevent, which is our standard flagship program for every South Asian and now available to everyone, not just South Asians alone. Stop D is a program that's modeled after the diabetes prevention program from the CDC and has achieved CDC recognition through 2029. Sparks is a new program that we've started utilizing the expertise that we have built around health coaching to offer it to individuals that have completed treatment for cancer and now are rebuilding their lives. And health coaching has been shown to help with longevity and with better outcome. These are all the organizations that have recognized our work. We have a list of accomplishments through the 20 years, but the one that we are here in this audience that I'd like to say I'm most proud about is the fact that we have 11 peer-reviewed publications. Dr. Molina is actually going to talk about some of those today and what and how we've been able to propose the changes that you see in the guidelines. We have promoted the CT scan and the use of the Lp(a) from the very beginning, and that now is part of the guidelines. The BMI, the lowered BMI cutoffs, and now this new marker that we have developed at the South Asian Heart Center to give a good assessment of your arteriosclerosis. This is our team, our core staff team. And besides this, we have a horde of coaches who are dedicated and passionate to work on this for the community. I just wanted to let you know that Anita Sate is going to be our moderator. Anita Sate has also completed 20 years at the South Asian Art Center. So it's her anniversary as well. And we wish her for literally participating in every fabric, every moment, every thing that we do at the center and doing it with such heart. Thank you, Anita. We've got a few programs to talk about. So next Tuesday, we had scheduled to start our new Stop Diabetes program. We would like for individuals who want to take care of their pre-diabetes and prevent diabetes kind of going forward to really look at this program that's helped so many individuals. And for the Mother's Day month, um, we have a special promotion for women at $5.99. So you can scan this QR code to schedule a free orientation and understand what that program is and how it can help prevent diabetes. This program is available through telehealth, so it's available to not just people within the Bay Area, but wherever they might be in the United States, um, as well as some foreign countries where we do get people joining our program. So please sign up and sign up your friends and family who need the help. I talked about the Sparks program. This is again a beautiful program that we have started. We already have 80 plus individuals that have signed up for this program, and we're already hearing from them on how it's helping them survive that rough road, post treatment of cancer. Again, you can schedule an appointment to understand this program. You can get your friends and family who might be suffering from cancer involved in this program as well. Many of you attended our Awake and Sleep huddle a couple of months ago in March, which was done by Dr. Shirsagar, where he presented kind of an Ayurvedic Vedic approach to sleep. That was so popular and so well received that we have actually decided to offer a two-part workshop series starting June 2nd on Tuesday, the first one, and a week later on June 9th, the second one. And it'll cover the foundations of restful sleep in part one, and in part two, optimizing sleep for mind, body, and spirit. And it will look at the science, but also the Vedic way to approach sleep. So please sign up for that one. The workshop is just $20 for each one of them, so $40. But I think it'll be worth your time, especially if you struggle with sleep. This would be an amazing way to address sleep. They're going to follow the book and provide you handouts of things that they are able to share with you from the book. And then finally, and this is actually a preview of what's coming with our workshop today, our huddle today, is the guidelines. And one of the key things the guidelines talk about is about South Asian ancestry and why individuals need to actually start screening at the age of 19. So we are offering a program for young adults in the community, 19 or 18 to 30-year-olds, to get their ABC risk profile, which is the comprehensive risk screening at the South Asian Art Center done. And it's going to cost them just $50. And so we invite parents to kind of, get their kids on board, or young adults who might be joining or hearing this workshop to make this viral in the young adult community. This is the best thing that we can do. And as part of the 20th year, one of our campaign promises, we call it the Billions of Heartbeats campaign, is to forge a shift in the direction of this epidemic of heart disease within South Asians in a generational way. And we can only do it with your help by getting all the young adults in the community screened as early as possible. So I really appreciate your help in getting young adults screened quickly. And through this year, we are offering this from Mother's Day to Children's Day. And that's part of seeking your help to build our community's health. But you can contact us at sahc@elcaminohealth.org. If you feel that you can help us with that campaign, you can call us at our number at 650-940-7242, and we'll post it in the chat so you have that link as well. The Thursday evening community health huddles are usually on the last Thursday of the month. This year, because Dr. Molina is going on vacation, we wanted to get his expertise before he went on vacation, and therefore we moved it up by a week. So thank you, Dr. Molina, for adjusting and being flexible. I really hope that you would think about being an ambassador by getting people to at least join these huddles. These are for free and available to the community. You can promote them at your corporation. You can promote them within your community, and you can promote them within your friends and family. So with that, just wanted to give you the QR code for the recording. That'll show up perhaps early next week in case you have missed it, or you want to forward it on to people who have missed it. So with that, I'd like to introduce Dr. Molina. Dr. Molina has been the medical director of the South Asian Heart Center for the past 20 years as well. And we as the community should owe Dr. Molina so much gratitude for making this important. I might get a little, teary-eyed about this because, he has been a friend, he's been a mentor, he's the one who got me on the path to meditation. I can't say enough about how much Dr. Molina has influenced my life. But more importantly, I think Dr. Molina understands the Vedic approach, a science based Vedic approach to life. And that's what we as community members can really, really tap in to, to blend the science on one hand with our culture and our upbringing and the very practices that are ingrained within all of us. Dr. Molina understands that. He understands the Sanskrit shlokas of the Bhagavad Gita. And on top of all of that, he's a very distinguished physician and cardiologist at El Camino Health. He did his medical degree from Yale University. He presented his MD thesis at the Joslin Clinic at Harvard. And he completed his medical, clinical pharmacology, and cardiology training at Stanford. He was faculty at Stanford Medical School and a Robert Wood Johnson Scholar. And he decided to do his clinical practice at El Camino Health and has been here literally all of those 20 years plus more. Dr. Molina's interests include the role of lifestyle factors and longevity and the epidemiology of coronary artery disease in all ethnicities, but specifically in South Asians. He's well versed in the ancient science of Ayurveda and long-term practitioner, and now a teacher of transcendental meditation as well. So with that, I'd like to welcome Dr. Molina. He's wearing his blue shirt today, so I tried to match him on that, except that blue is not the color for today. So Dr. Molina, could you start with telling us about the colors of the week and then getting into our presentation?
Well, thank you, Ashish, for the introduction. And it has actually been my pleasure to be at El Camino Hospital for the last 36 years and to be the co-founder and medical director of South Asian Heart Center for the last 20 years. I echo the gratitude towards Anita, as well as I go back to you and the effect that you have also had on me and permitted me to sort of develop as an individual physician, being able to sort of provide we have discussed to be the science-based Vedic approach to health and create the MEDS program, which is very much the basis of our heart disease and diabetes prevention program at El Camino Hospital, but which has also been used in other settings, particularly in the San Francisco School District. Now, in reference to the days of the week, when someone has to wear a tie every day and you have many, many ties, you need to sort of come up with a code so you can go in and out and dress up quickly. Now, the days of the week are named after the visible planets. And those visible planets have colors. So, for example, a Monday stands, which is not a planet, but Monday stands for the moon, and so you would wear something white on Monday. Tuesday, which in Spanish is Martes, and Martes is a planet known as Mars, is a red planet. And Wednesday, which in Spanish is miércoles, stands for Mercury, and Mercury is a green planet, a green planet, and so on. So today should be wearing the color of Jupiter, but I didn't have a clean shirt in that color. So here I'm wearing a blue shirt today with one of my favorite Save the Children ties that I probably bought about 30 years ago. So that's not the reason why we're here today. We're here today to talk about the recent guidelines that have been published by the American Heart Association and American College of Cardiology. Um, they actually have been sort of defined as new tools, and by Ashish, who has highlighted this issue of smarter prevention. But one of the reasons that we are actually giving this presentation today, and could have given also another presentation about the management and treatment of uh, early high blood pressure and high blood pressure, is that both the American Heart Association, American College of Cardiology, and many other organizations have actually now incorporating what the South Asian Heart Center has been doing for the last 20 years. Or motto over those last 20 years is that lifestyle is foundational, is primordial. And now lifestyle changes are recommended in the prevention of when you see early hypertension, and it also being spread out to the treatment of high blood pressure, recommendations of sort of how to live, inclusive of transcendental meditation, which we have been um, which we incorporated at the beginning of the South Asian Heart Center. That was actually in 2025 for hypertension, and now in 2026, the American Heart Association, College of Cardiology has now come on with their guidelines for the management of dyslipidemia or abnormal lipids. Now, a little bit something like an aside, a tangent in parentheses. We don't want to give you the impression that lipids explain most of coronary artery disease, but these are the guidelines for management of dyslipidemia. So we're going to be talking about lipid factors. Now, why is it that I say that? Because since the beginning, when we started 20 years ago, we tested for everything. We did not know what explained the pandemic, the epidemic of early coronary artery events or heart attacks in young South Asians. So we tested for everything. And as a result of our research enterprise, in which we have published 11 papers, as Ashish mentioned, we have learned from our work and we have been able to develop and fine tune our methodology, which then now we are not surprised that the American Heart Association is also including some of the pillars of our methodology in the recommendations for the prevention of any heart attack. So let's just, in context, coronary artery disease remains the biggest killer in the USA and around the world. So 1 in every 3 deaths is a death from a heart attack, and the rest you already know. This is extremely expensive to the American healthcare system. Now, what is a heart attack? And I think that it's really important to sort of define that. A heart attack occurs when a coronary artery, which supplies the blood to the heart muscle, suddenly becomes completely blocked, cutting off blood supply to that part of the heart. Now, the heart is dependent on blood flow. In fact, it is more dependent on blood flow than most other organs because it extracts the oxygen from that blood flow almost 100% all the time. So the only way that it can increase oxygen delivery is by increasing flow. And a heart attack eliminates that flow immediately. And if there is no ability to reestablish flow, that heart muscle dies within 20 minutes. And that actually is what we know as a heart attack. Therefore, when there is a sudden occlusion of a coronary artery, we definitely need to have prompt therapy and we need to understand the symptoms so that we can recognize them and then seek medical attention. Now, there are 5 types of heart attacks, and there are defined by EKG changes, by clinical history, by blood tests. In the emergency room, heart attacks are divided in two, and they are divided in two formats on the basis of the ECG or EKG. One is where you have an elevation of the ST segments on the EKG. That usually represents a total occlusion of a major coronary artery and usually represents that the whole depth of the heart muscle is at risk of dying. We also have non-ST7 elevation heart attacks where the person has chest discomfort, has evidence of heart damage, but there is no elevation in the ST segments. Many times there is depression. And that means that there may be a partial occlusion, an on and off kind of phenomenon, and that the damage is mainly at the deepest level rather than the full thickness, but just at the lower, deeper level of heart muscle. They have different prognostic implications. Non-STEMIs or non-ST7 elevation myocardial infarctions are initially treated with medical therapy and cooling the system down, and then the person may have an angiogram afterwards. But ST7 elevation MIs require immediate therapy, and we need to open up that artery within 90 minutes of the person arriving to the emergency room. So that's the EKG criteria of the 2 types of heart attack. Now, in the cath lab, we actually define heart attacks anatomically, depending on where the occlusion of the coronary artery is, and it's listed here for your review. In the definition of heart damage, so when we're talking about heart attack, when we're talking about heart damage, we're actually talking about 5 types, but mainly 2 types that are clinically significant. One is when you have plaque rupture and a thrombus, a blood clot forms in the coronary artery. That's the typical type 1 heart attack is you get chest discomfort, you end up in the ER, they take you to the cath lab, they open up the artery. And that usually is associated with an ST segment elevation heart attack. Now, there's a second type of heart attack that is very common, which is what we know as a type 2 heart attack. And that can happen if your heart is going really fast and there's not enough blood flow going, like an arrhythmia. That can happen if you have an infection, which is stressing your system. That can happen if you are emotionally stressed and you're having what we call an adrenergic cardiomyopathy or broken heart syndrome. And I have seen within the last year, as a result of the knocking protest, 2 persons with broken heart syndrome as a result of the severe stress and anxiety associated with the protection of our democracy. There are 3 other types of heart attacks. Type 3 is when someone has a sudden cardiac death, and that sudden cardiac death arrives to the emergency department. There is no time to do an angiogram. There's no time to do an EKG, but we assume that that is actually the result of the ultimate result, which is no matter if it's a pulmonary emboli or whatever, the heart has stopped working, stopped beating, and that's how we define the sudden cardiac death. Lastly, type 4 and type 5 are heart attacks that are iatrogenic. They are the result of our treatment, such as when there is a stent related or angioplasty related occlusion or reocclusion of a stent, or someone has a bypass associated with heart damage. Now, heart attacks actually, unfortunately, are the first presentation of coronary artery disease in about 62% of men. And the next slide will show you why. That is, most of the time, the person who's having a heart attack has had no cardiac symptom to suggest that there's heart disease. And the first evidence of that heart disease, symptom of that heart disease, is an acute heart attack. And that happens in about 62% of men and about 46% of women. Now, the way it goes is this way. Heart attacks happen unexpectedly. It's just like, the baseball just came out of right field and sort of splashed you on the head. That is actually what's happening. In many ways, they're just accidents where there is an acute inflammatory process and a plaque ruptures leading to either sudden cardiac death or sudden acute heart attack or MI. So this is how it goes. And I mentioned that in about 50 to 60% of people, the first indication is a heart attack because there's no angina. So what do we mean by that? The way arteriosclerosis happens is that you have an inflammatory process in the wall of the coronary artery. That inflammatory process many times is precipitated by the deposition of cholesterol. And that is where the cholesterol theory comes along, and that is cholesterol is primordial in creating a coronary artery plaque. Now, I will show you later that the relationship between your blood cholesterol and what is in your coronary artery is poor, okay? But there is cholesterol deposition in the arterial wall that cause on for inflammation. We have foam macrophages. It's like developing a cyst or a pimple in your coronary artery. That actually can remain stable, that can quiet down, or if the inflammation continues, you can actually rupture the thin plaque cover, and that rupture leads to deposition of a blood clot and a heart attack. So most people will be surprised that most heart attacks do not happen in coronary narrowed arteries. It happens in arteries that are not narrowed enough to give you angina or to give you symptoms. Heart attacks where you have a narrowing only occur in about 18 to 30% of the cases. And it's not because of plaque rupture, it's because a blood clot forms on the cap of the blockage. That's why when we take a patient to the cath lab when they're having a heart attack, our job is relatively easy because we're not going through this kind of narrowing. We're going through an artery that is like that is full of clot, and the clot is easy to go through. So this actually is data from all those trials that were done with TPA when TPA came out. And they're called the TIMI trials, and there were multiple TIMI trials. And what we learned is that in about 68% of heart attacks, the narrowings that led to the heart attack were less than 50%. And in only 14%, you had narrowings of about 70%. So that's very telling because many times we say, oh my God, I have a 90% blockage. I better open that up because next time it will be 100. That is not the pathophysiology. The pathophysiology is that it is unlikely that 90% blockage is going to give you a heart attack. Most likely, the heart attack will occur where there is actually no significant blockage. And in fact, in 12% of the cases, there is no pre-existing blockage when the plaque ruptures. Now, there is a relationship between LDL cholesterol and heart attacks, and that relationship is thought to be linear. Now, this is actually a little tricky because the low density cholesterol or the LDL cholesterol, it does not fit into any predictive equations to determine your risk of heart attack. It did not fit in the Framingham profiles that started the whole process and connecting cholesterol with cardiovascular disease and heart attack, and did not actually are not part of the pool cohort equation, and they're not part of the most recent equation we call the prevent equation. This linear relationship is a result of our findings in giving medications to lower the cholesterol with the use of statins. Statin therapy is associated with a drop in LDL cholesterol and is associated with heart attack incidence. And from that data, we have actually come with this kind of linear relationship. But it's different to say, oh, LDL is the cause than to say the drop of LDL with medications is associated with the drop in heart attack. So you need to sort of recognize that and take that into consideration when you analyze the data, because the new guidelines, when we're talking about the treatment of dyslipidemia, we're talking about treatment with lipid lowering therapy or LLT, and the best lipid lowering therapy that is associated with the best outcomes is actually statin therapy. And when we say outcomes, is heart attack decrease, the drop in heart attack incidence, not just LDL levels. So what are we talking about today? And I know that I spent a lot of time already talking about ties and shirts, but we're going to talk about our guidelines, the new guidelines. And we're going to describe, we're going to define who should be evaluated and when, and what should be measured, and how is it that we calculate the risks? And what do those risks calculate? In the old days, we could only calculate a 10-year risk. Now we can calculate a 10-year risk and a 30-year risk. And how is it that we develop a step or organized or a treatment plan for someone who is actually considered to be at risk? And what is the role of pharmacotherapy, and what is the role of lifestyle and how we live? And then finally, what are the medications that are available? So, as you know, why the new guidelines? Well, because people are still dying of heart attack, and heart attack continues to be the main problem that kills people and leads to, and its consequences uh, of admission to the hospital with problems like arrhythmias, congestive heart failure, and recurrent heart attacks. For a long time, we have known that the regular lipid panel fails to capture the overall risk. And this is what we recognized 20 years ago and created our own risk assessment that went just beyond getting a lipid panel. We now are understanding of the roles of inflammation. We understand that kidney function is actually an assessment of vascular function, and that itself has an effect on vascular physiology and pathophysiology. And we also understand that different groups of individuals in our society have different risk profiles. Now, this is sort of a classic slide produced by the American Heart Association, which just sort of describes what we at the South Asian Heart Center call Health Version 2. And this is Health Version 2, which is directed at identifying and managing risk factors for anything, but in this case, in our case, for cardiovascular disease or heart attack risk and diabetes. So the American Heart Association, American College of Cardiology says, well, there's stage 0 where you are happy-go-lucky, you have no problems, and you don't have any major risk factors. Stage 1 is when you start having the beginning of risk factors. That is, you're being surrounded by weapons of mass expansion. and therefore your belly starts to get bigger and your blood sugar starts to go up. And as a result of your bigger belly, you start developing high blood pressure. And those things then lead to established stage two, where now all of a sudden you don't have a heart attack, but you have hypertension. You have abnormal lipid panel. You have abnormal kidney function. You have diabetes. And then you get to stage three, where then you have plaque, just like I showed you on that cartoon of the coronary artery that is without any symptoms. And then unfortunately, stage four comes along and that plaque ruptures and you have a heart attack. The most important thing is not to mistake it for indigestion and to diagnose it as it is and then present to the healthcare provider to deal with the problem. Now, there has been a big shift in guidelines, and that's what we have in this presentation today. The latest guidelines were in 2018, and they suggested that people be evaluated after the age of 40. And the new guidelines in 2026 suggest, well, why wait until 40? Let's start at the age of 30. Why? Because heart disease may not start, you may not have clinical heart disease at 30, but it starts early. And if you don't pay attention early, then you're always swimming at the back, meaning you're not preventing, you're treating. So we truly want to prevent the problem rather than to be at the level of treatment. In 2018, it was mainly focused on LDL cholesterol. Why? Because we were so impressed by the benefit from statin therapy. Now in 2026, not only do we pay attention to the LDL cholesterol, which continues to be our target treatment, but we also look at non-HDL cholesterol. We look at Lp(a), we look at inflammatory markers like CRP, we look at ApoB to get a better comprehensive evaluation. The South Asian Heart Center has looked at ApoB and the non-HDL cholesterol, and we actually have published important information and findings in reference to the ApoB and the non-HDL to ApoB ratio, which I will show you sometime on. Now, they came up in 2018 with the pool cohort equation, or PCE, as we will abbreviate it during this presentation, PCE, the pool cohort equation. Now, this overestimated risk. Why? Because it uses age as its main risk factor pusher. It's the main driver of risk in the pool cohort equation. Then followed by the presence of tobacco use, hypertension, diabetes, and total cholesterol to HDL ratio. That pool cohort equation, which we studied and has studied at the South Asian Heart Center, in fact, is like flipping a coin. It's a 50-50 kind of thing in predicting the presence of coronary artery disease and the true need for statin therapy. And you can actually go to our paper published in 2023 in the Journal American Heart Association, and that will become that is actually demonstrated there. The PREVENT equation actually looks at 10 and 30-year risk and is better calibrated, and it takes into consideration your zip code and your renal function and your body mass index, which are important factors for that predispose people for diabetes and heart attack and heart disease. Lifestyle is just mentioned in the 2018 guidelines, but lifestyle is foundational now in the 2026, which is actually what the South Asian Heart Center has been doing under our MEDS platform, where we pay attention to meditation, exercise, nutrition, or diet, and sleep. And sleep actually is now part of the American Heart Association 8, but 15 years ago, it was the American Heart Association 7, and sleep came on. Sleep has always been an important factor at the South Asian Heart Center. And actually, in the Gita, it said that yoga is for he who does not sleep or sleeps too much. And there we go. So anyhow, now we have this sort of CPR framework, which is we calculate We personalize risks and treatment, and we refine it. How do we refine it? Well, we can refine it with coronary calcium scanning. We can refine it with CRP. We can refine it with other biomarkers. We can personalize it because of the importance of ancestry. Um, Now, what is included in the evaluation of someone in 2026 and what has been included at the South Asian Heart Center for the last 20 years? Well, obviously, age, sex, blood pressure, total cholesterol, HDL cholesterol, the presence of diabetes, now kidney function, and body mass index. This will be surprising to you, but body mass index is actually a much more potent predictor of heart disease and hypertension and cancer and diabetes than cholesterol. Now, that's been published in the literature, but until recently, we did not have any medicines to deal with BMI. So most of science will not talk about BMI, but even though the publications are there, and I'll show you what we have found at the South Asian Heart Center. Now, we start at the age of 30. Why? Because we know that this starts early on. This actually starts in childhood. We pay attention to kidney health, obviously BMI, and we use population data, meaning we now, and I'll show you, some ethnic groups have more heart disease than others. We can now better calibrate than we could calibrate with the pool cohort equation. We can calibrate as per zip code because economic well-being is associated with a different risk profile. So how do we calculate the 10-year risk? We start at the age of 30. We, as mentioned, we are paying attention to other factors, and we have improved discrimination. We are now able to actually identify 4 factors: very low risk, borderline risk, intermediate risk, and high risk. Now, this is not new. This has been going on since the Framingham study 40, 50 years ago. When we came up with a pool cohort equation in 2018, we recognized that most heart attacks occur in the intermediate risk group, not in the high risk group. So, which is sort of interesting, again, demonstrating how poor these equations were in identifying risk. And when we compare it to coronary calcium scanning, which is a pillar of the South Asian Heart Center, we actually know that the coronary calcium score and heart attack is linear versus with all these equations, most heart attacks occur not in the high risk group, but in the so-called intermediate risk group. So we know that a 7.5% chance of having a cardiac or major cardiac event within the next 10 years is a trigger for pharmacotherapy. So who should be assessed? Anyone over the age of 30 with this protocol. And now, what are the things that change that? Well, there's a family history of premature coronary artery disease. Now, is all family history all the same? The answer is no, because if for family history to, first of all, family history is not on the top 9 risk factors in the Interheart trial for heart attack, and that was 15,000 heart attacks across the world. But if your father or male first-degree relative has had a cardiac event below the age of 55 or less, that's a significant risk factor. If your mother or any female first-degree relative has had a major vascular event below the age of 65, that is a significant risk factor. If your father had a heart attack at the age of 80, that is not a family risk factor. It's not a genetic factor. It's just that your father at the age of 80 is suffering the effect of time, not the results of poor genes. Now, how is it that we assess? Where do we start assessing? We mainly start assessing looking for metabolic disorders. Why? Because it starts in many cases with your belly. It starts with the accumulation of extra calories. It starts with this metabolism. Rather than dyslipidemia, it appears that the driver is age and this metabolism, and then dyslipidemia. So this is actually, here we use the word adolescence, but I remember in medical school looking at the aortas of newborns that had disease, looking and finding that in those aortas, there was already the presence of plaque. So plaque happens to all individuals from an early age. And what does that mean? Well, there are small little nests of inflammation that can happen in the vascular tree, even at an early age. And just like when you have a pimple, that pimple can come and it just can go away. But with time, they can accumulate, and then you have buildup of arteriosclerosis. The new guidelines include ancestry, and they now include South Asians. This was not found in that was part of the pool cohort equation, but now the guidelines recognize that individuals that have an ancestry that goes back to the Indian subcontinent have a 2 to 4 increased risk of cardiovascular events when compared to other groups, that the risks occur at a lower body mass index and at different cholesterol levels, and that many heart attacks will start happening at the age of 40 and in the 40s. In the typical non-South Asian population, you see the upstick at the age of 56. In South Asians, you see that upstick in the mid 40s. Other populations are also at risk, like Black and African Americans. They tend to have a higher incidence of hypertension, and that hypertension drives an increased incidence of vascular events, particularly stroke. The Hispanic population is a little different. They tend to have fewer heart attacks in reference to their metabolic derangements and lipid derangements, but they have a higher incidence of diabetes and a higher incidence of stroke rather than heart attacks. We call that the Hispanic paradox. And lastly, no matter the ancestry, all of us humans we are very similar to each other, and all this ancestry in many ways is just it's a millimeter depth in depth, and there actually cardiovascular disease affects everybody, and the South Asian Heart Center is available to everybody. Now, lipids should not be just considered in isolation. LDL cholesterol does remain important, particularly the LDL is greater than 189. That's when you see the greatest effect. People with familial hypercholesterolemia truly have premature heart disease. But LDL alone does not capture the whole total risk. In fact, many times it misses risk. And in many people that present to the hospital with a heart attack, they will have perfectly normal cholesterols. And in 23% of people, their LDL cholesterol is below 70. So we are paying attention to other atherogenic particles beyond LDL. And those are ApoB. Now, what is ApoB? ApoB is an apolipoprotein. So as you know, cholesterol does not circulate in solution in our blood. Cholesterol is carried by particles. Those particles of cholesterol are made up of an ApoB molecule. They contain, every particle of non-HDL cholesterol contains one ApoB particle. And these ApoB containing particles, their job is to transfer cholesterol from the liver to the tissues. That cholesterol is used to create sex hormones, stress hormones, and that cholesterol is used to build your cell membranes, because the animal cell membranes, and we are animals, we belong to the animal kingdom, is made of cholesterol esters and lipoproteins, as well as triglycerides, but mainly the cholesterol esters. So LDL is put out by the liver so that we can actually rebuild our cells. But we then have a way of assessing total non-HDL, or excuse me a second. Uh, Thank you. Total non-HDL atherogenic particle numbers by measuring the ApoB number. So ApoB and non-HDL cholesterol are very equivalent. All non-HDL cholesterol has one ApoB particle. So ApoB tends to be better predictor than LDL cholesterol because it carries the whole atherogenic burden. Now, it's easy to calculate. First, you can send a lab test for ApoB, or you can measure the non-HDL cholesterol by just taking total cholesterol and subtracting HDL cholesterol. You have to be careful, though, because that is under a range of depending on what the triglycerides are. If the triglycerides are very high, you cannot really use this formula consistently. Now, so what is ApoB? Well, I just mentioned what ApoB is. It's a structural protein that is in every non-HDL particle that moves this non-HDL cholesterol around the circulation. It represents the total atherogenic burden that is circulating in our bloodstream. And we have actually been able to use this ApoB and created our own formula. We have been the first ones to publish this, and we published this in 2023, and I actually would show you the data. ApoB is a way of assessing total concentration of cholesterol per particle of atherogenic cholesterol. And this is what we reported. This is an interaction between coronary arteriosclerosis or coronary calcification with age. The older you get, the more arteriosclerosis you get. However, that is attenuated or magnified by the concentration of cholesterol particles, of cholesterol per particle, which is easily measured by a non-HDL cholesterol to ApoB ratio. And as you can see, that if your ratio is less than 1.4, about 1.38, 1.35 or less, you have big time coronary calcification. You have big time rise in coronary arteriosclerosis. If you have a high ratio of 1.6, 1.8, no matter as your age, you have minimal coronary calcification, demonstrating that this dyslipidemia, so this is independent of LDL cholesterol. It is a dyslipidemia, meaning the lower the ratio, the lower the concentration of cholesterol particles, cholesterol per particle of non-HDL cholesterol. That means smaller particle, and there's more coronary arteriosclerosis. So then, knowing this, what are our goals of treatment? So our goals are listed here, both with LDL cholesterol, non-HDL cholesterol, or ApoB. And this is for you to sort of review. This is all available, depending on your risk profile. Obviously, we want to sort of have a lower cholesterol level, but we also recognize that even 50% of people who have very high cholesterol, extremely high cholesterol, do not have any arteriosclerosis. So then you need to do a little better fine tuning in that situation. And that's why we look at other factors, particularly coronary calcification. And this is all listed here. People who are at high risk for heart attack, people like with diabetes or high coronary calcium scores who have, repeated angioplasties or stents, the goal is to get an ApoB below 55, to get an LDL cholesterol before, it says below 40 here, but 55 is more realistic. At least that's what the guidelines in practice state. So how do we get this personalized? Remember the CPR that we were talking about. And we look at family history, men below the age of 55, females below the age of 65. We look for the presence of diabetes. We look for the presence of inflammatory disease. What are inflammatory diseases that change the risk profile? Well, inflammatory problems such as rheumatoid arthritis, such as polymyalgia rheumatica, such as lupus. So blood markers, which we measure at the South Asian Heart Center, LP little a, high sensitivity CRP, which is a measurement of inflammation, high triglycerides. Now, high triglycerides are a risk factor when they're really postprandial, when there's prolonged hypertriglyceridemia. That is also associated with small particles of LDL or a low ratio of non-HDL cholesterol to ApoB ratio. And then when you have a mixed condition, multiple factors, then we pay attention to the LDL level. And we pay attention to LDL levels of 160 to 189, but not by isolation, but in presence of multiple other factors. In the absence of other factors, that LDL between 160 and 189 is non-predictive. And then, particularly for women, history of complications in pregnancy, such as preeclampsia, gestational hypertension, gestational diabetes. They all increase the risk of cardiovascular disease in women, and early menopause, meaning menopause below the age of 45. Now, let's talk about the other markers that the American Heart Association is now recommending in testing that we have been testing for the last 20 years. And one of them is lipoprotein little a. When we started the South Asian Heart Center 20 plus years ago, we thought that LP little a explained the increased risk of heart attacks in South Asians. And I don't think that that is the case anymore. Now, LP little a does increase the risk of heart attack in anyone. Now, if by the age of 80 or by the age of 65, lipoprotein little a has not increased your risk of heart attack, it probably will not increase your risk of heart attack. But the issue with LP little a is that it does not cause arteriosclerosis, meaning it does not drive coronary calcification, but it causes blood clots. It stimulates blood clots and it stimulates plaque rupture. So we actually think it's important to measure the LP little a, not because we can treat it, but because we know that if you have high LP little a, you need to pay attention to the other risk factors that can be changed. Now, there are new pharmaceuticals that are being studied and developed with the assumption that lowering the LP little a will lead to fewer heart attacks. Those studies are in progress. Now, there are drugs like Repatha or PCSK9 inhibitors that will lower the LP little a, but we do not know that if that lowering of LP little a is associated with fewer heart attacks. We know that drugs like Repatha by themselves do not affect inflammation, and all the studies that have shown PCSK9 inhibitors to prevent heart attack have always been done in the presence of maximum statin therapy. But the presence of a high LP little a then guides the aggressivity of therapy to the point that if you have very high LP little a, it can increase your risk fourfold. If you have mild elevations in LP little a, please don't be overly concerned. I mean, it can just increase your risk a little bit. I mean, smoking will do more for you, more risk than having a slight elevation in the LP little a. For example, you smoke, your risk goes up to 200 to 300% right off the bat. If you have an LP little a between 75 nanomoles to 125, it increases the risk 40%. Now, inflammation. And inflammation is central. That plaque that I show you at the beginning of the talk with that cartoon of that artery, all that was driven by an inflammatory response to cholesterol in the vessel wall. It was driven by macrophages going in and becoming foam cells. These foam cells that are involved in that inflammatory process, they release interleukin. Interleukin goes to the liver and tells the liver, make CRP. Now, the CRP is just a marker. It doesn't itself involve in inflammation, but that CRP is actually a marker that there's inflammation somewhere. And therefore, we can assess the CRP and identify the individual who is under inflammatory pressure. Now, many other conditions other than arteriosclerosis are associated with elevations in CRP, like having poor dental hygiene, like having rheumatoid arthritis, lupus, like having HIV. They all drive this inflammatory picture. Psoriasis drives this inflammatory picture. So it's just not vascular inflammation. The issue, though, is that CRP as a marker is very transient. So CRP can predict populations, but in an individual, there's too much noise, meaning you got a little cold, your CRP will go up for 3 weeks. You got a vaccine, you have allergies, you actually went to the gym and you sort of sprained your knee or played tennis and you wiped out. That will elevate your CRP. So there are many other factors that affect the CRP that are not necessarily related to vascular health, but there's a clear-cut relationship, and you can see it here from the response to statin therapy. Statins are unique because they not only lower the cholesterol, but they lower the inflammation. And in fact, it is thought that it's the inflammatory drop that leads to the decreased risk of heart attack. And this is from the Jupiter trial that was published in the New England Journal of Medicine, with about 5,000 subjects followed for 5 years on rosuvastatin. And they studied people with normal cholesterol. And they actually, and they had, and also high CRP. The people who got the best response to therapy were people who had low CRP and low LDL cholesterol. They had the fewest events. And there were people who had low cholesterol but high CRP, and they still had very high events. But then in the middle is high cholesterol but low CRP. So ultimately, this informs us that CRP is the driver, and it explains a lot of the benefit from statin therapy. So that's actually the inflammatory markers. We incorporate them at the South Asia Center since almost the beginning, and they're now part of the American Heart Association recommendations. Well, the prevent formula includes glomerular filtration rate, and it also includes the ratio of albumin to creatinine. That's the UACR as spelled there. So what is the UACR? It just indicates that your glomerulus, which is a modified membrane that interacts with a capillary, is leaking protein, has become leaky. So that's just an indication that there's some vascular damage at the level of the kidney and some membrane damage at the level of the kidney. And that is indicative of increased risk of heart disease and heart attack. Decreased filtration through that capillary bed, which is measured by the creatinine or the EGFR, which is glomerular filtration rate, is also a factor that predisposes you to cardiovascular disease. So, and chronic kidney disease is really no longer just a risk enhancer, it's a problem. And it requires that people with renal failure should be treated like if they were at risk of having a heart attack, just like people with diabetes. So let's just talk about what are the risk enhancers that are now part of the guidelines. Well, family history, as we described. Men before the age of 55 or 55 or below, women below 65 or below. Elevated Lp(a), particularly when it's greater than 125 nanomoles or 50 milligrams per deciliter. Persistently elevated triglycerides, meaning postprandial, enhanced, prolonged lipid elevation after a meal. Elevated hsCRP over 2. Chronic kidney disease, chronic inflammatory problems like rheumatoid arthritis, metabolic syndrome, which is as bad as having diabetes as a risk factor. We talked about uh, a pregnancy history, preeclampsia or premature menopause, menopause below the age of 45, preeclampsia or gestational hypertension or gestational diabetes, elevated ApoB, and in our profile here at the South Asian Heart Center, as reduce non-HDL cholesterol to ApoB ratio, and the presence of peripheral arterial disease, such as an abnormal ankle brachial index. What does that measure? Measures that there is peripheral arteriosclerosis blockages limiting the blood flow to your feet, usually starting in the femoral arteries. So most arteriosclerosis, in fact, starts in the femoral arteries. So we also use this at the South Asian Heart Center, the coronary calcium scan. And this now is integrated into the American Heart Association guidelines. So how do we use the coronary calcium score? Well, we use the coronary calcium score in people that are intermediate, that we know that there are an increased risk, but not maybe. So, for example, someone with diabetes, we don't need to check their coronary calcium scan. We know that they are an increased risk. So we are not going to change your treatment depending on the coronary calcium scan. Now, someone who has risk factors and should be taking a statin, but they have side effects, then we can use the heart scan to see if we really have to push or we can relax. Why? Because if the score is 0, the likelihood of a heart event is very, very low. So then we don't push against all the problems that the person is having as he's managing his risk factors with statins. We use the coronary calcium score to resolve discordant data, where one thing pushes for therapy and another one says, oh, therapy is not indicated. And lastly, it actually informs us. Does this person have arteriosclerosis and benefits from therapy, or this person does not have arteriosclerosis? Why is that necessary? Because we know that everything that we just talked about, all the markers that we can access, all the markers and all this history is not very accurate to the point where most heart attacks occur in the intermediate risk group. So therefore, it is very important, at least in our program at the South Asian Heart Center, to inform the correct diagnosis. It's really a diagnostic test. We don't need to guess. We don't need to come up with percentage. Now, these formulas are still important because even that they're not 100% or even very close to that in diagnosis arteriosclerosis, they still are pretty good in identifying the person who may have a vascular event. So there's a separation between people with arteriosclerosis and people with arteriosclerosis who are at risk of having a cardiac event. Not most people who have arteriosclerosis have no cardiac events. So the formulas are still very important. Paying attention to LP little a, paying attention to HRCRP, paying attention to ApoB is important. So how is it that we use the coronary calcium score? Well, we use it to sort of identify what is our goal of therapy. Coronary calcium score is 0, you still need to live a good life. Why? Because if you live well, you live well. You live well, you live long. If you have a score of 0 and you live poorly, you don't live well and you don't live long. Other conditions other than a heart attack will get you. If you have a score between 1 and 99, or if your LDL cholesterol, if your coronary calcium score puts you at a 75 percentile in your age group and gender group, then your LDL with pharmacotherapy should be below 100. If you have stronger coronary calcium, you have more coronary calcification, well, you really want to push that LDL below 70, maybe below 7, maybe below 55. If you have diabetes and a score of 500, your goal is an LDL below 55, a CRP below 2. So now, when is it that you start statin therapy? And this may be a little controversial. Why? Because when you're taking a statin, you incur the cost of going to the lab. You incur the risk of having side effects. And sometimes they're minor, but sometimes they're significant. In 1 in 10 people may have significant side effects. And statins also increase your risk of diabetes. So you have to be judicious and not just why don't we try a statin? You need to have some intelligence and some kind of protocol to decide with your patient or to who should be on LLT or lipid lowering therapy and what the goal should be. Now, the good news or the bad news. And the fact is that no matter everything that we have discussed and no matter how great the LLT or lipid lowering therapy is, we still, despite the presence of lipid lowering therapy, which what is the best so far, which are statins, we're still having cardiac events. So in the 4S trial, which is a very high risk profile, people with diabetes and cardiovascular disease, 62% of heart attacks were still happening. The drop was that of 34 to 38%. In the lipid trial, which is a secondary to prevention trial, 25% of people had prevention, 75% of heart attacks still happen. So about 60 to 70% of heart attacks are still happening despite statin therapy. In the people with primary prevention, people without any symptoms, just getting a statin just to see about 40% of heart attacks are still happening, or 38%. So this is also very important to recognize. We have ways, but with pharmacotherapy, we have ways that are great because I'll take a 40%, 30% reduction, but you still have that 70% reduction. Now, how does that compare to lifestyle factors? Well, those lifestyle factors that we are called the MEDS program at the South Asian Heart Center, they have not been compared, by the way, against statins, but this is what we see. This is actually from this is from a Swedish study in men. These are factors that were associated with a 79% reduction in heart attack over 5 years in men. Okay? And that's a 75% reduction in heart attack risk. In a mixed population of both men and women, followed for about 8 years, you can actually see a 93% reduction in diabetes, an 81% reduction in heart attack, 50% reduction in stroke, and a 36% reduction in incidence of cancer. It's not a competition between LLT or lipid lowering therapy and lifestyle therapy. They are additive. But I just you can be taking the statins, but you're going to McDonald's and watching TV all day and going to bed at midnight watching video games and arguing with your loved ones. You're not going to get what you should be getting from the statins. It's like pine box by bedside. So you have to live well to live well. So clearly, if you are at risk and significant risk, pharmacotherapy is important, and it is important to start early. And the intensity of therapy is dependent on the severity and degree or risk. And there are many ways of identifying that, as we just discussed. Coronary calcium scanning at the South Asian Heart Center at the urging of PK Cha 20-something years ago when we started, we developed a protocol. Our protocol was we would not scan women below the age of 45, and we would not scan men below the age of 40, because we did not want to expose people to radiation who were still planning to possibly have a family, recognizing that there is no safe level of radiation. That age cutoff now is incorporated in these guidelines for coronary calcium scanning. Now, what are the other non-statins lipid-lowering therapies? Well, they are ezetimibe or ezetimibe. What do? They can decrease your LDL between 10 to 20%. Now, ezetimibe, in addition to statins, can decrease the risk of heart attack by a little bit. By itself, it does not. It has not been tested by itself and shown to decrease heart attack risk. PCSK9 inhibitors can have a dramatic drop in the LDL cholesterol, but they do not affect inflammation. So all the PCSK9 inhibitors that have shown 7 to 30% reductions in heart attack incidence have always been in the presence of maximum statin therapy. Bempedoic acid, which was recently found to decrease LDL cholesterol by 18 to 25%, in the studies that look at outcomes, decrease heart attack risk by 7 to 17% as compared to 30% with statins. And injectables that have an effect in your messenger RNA and in the production of LDL, they can decrease the LDL with a shot every 6 months by 50%, but they have not been shown by themselves to prevent heart attacks. We're doing all this because we want to prevent heart attacks, not because we want to make the numbers look good, just the numbers. So what are the residual risk markers? Well, the LDL does not just look at it's not enough to look at residual risk. We have to address inflammation. We have to address other metabolic derangements. We call this metabolism. And we need to pay attention from early on to lifestyle. So we begin different now, 8 years later, from 2018. Now in 2026, we begin at an early age, 30 years, according to the American Association for South Asians. Why not pay attention at the age of 18, 19? Are you exercising? Are you sleeping well? Are you actually eating your fruits and vegetables and nuts and stuff like that? Why? You start now, you persist. You don't start now, then you'll be treating it with then. So, and your children will then automatically inherit your good lifestyle. How do we assess our risk? We use the prevent formula, which is very easy to do. How do we include the whole picture? Well, we can order biomarkers like Lp(a), which are not part of the prevent formula. We can measure the non-HDL cholesterol to ApoB ratio. We can look at CRP. And if there are issues of lifestyle or if there are complicated issues of this metabolism and dyslipidemia, we can then refer to an experienced cardiologist or the South Asian Heart Center who has experience in helping people change the way they live. So what is our experience? Well, our experience in identifying the severity and calculating the severity of coronary arteriosclerosis as measured by coronary calcification is that clearly the older you get, the worse it gets, meaning age is a big driver of arteriosclerosis. That's not news, we know that. Body mass index, BMI, very important, second after age. But very close to it is dyslipidemia. And how is this dyslipidemia assessed? Not by measuring the LDL cholesterol, which has no role here, but measuring the non-HDL cholesterol to ApoB ratio, and a ratio below 1.4 increases your risk, as I show you, of high coronary calcium scores. Smoking is bad for you. Elevated fasting blood sugar, this metabolism, also drives your coronary arteriosclerosis and your diastolic blood pressure. Diastolic blood pressure is a significant marker for progression of coronary arteriosclerosis. And in fact, these 6 markers explain about 30% of the coronary artery disease or coronary arteriosclerosis severity. The other 70% is unexplained. And now, why is it 30%? Well, it's 30% because we include the non-HDL cholesterol to ApoB ratio. If we were to take that out, like other studies have shown, it's only 22%. So we can only, and despite everything that we have discussed, we can only explain the severity of arteriosclerosis at the South Asian, 33%, 30%. You go somewhere else, about 22%. So this is, or these are our ABCs. Look for a heterogenic profile. This is what we measure to the left. Look at behavioral profile. That's listed here. Meds. And then also look at the cardiometabolic profile. What is your blood pressure? What is your fasting blood sugar, your A1C? Recognizing the role of this metabolism as driven by body mass index, abdominal waist, insulin, hemoglobin A1C, fasting blood sugar, and blood pressure, which are the markers of metabolic syndrome. Any questions? So bottom line is the South Asian Heart Center is already aligned with the 2026 American Heart Association, American College of Cardiology guidelines. We have a 20-year experience in alignment and in sort of using those guidelines to direct or counseling to our patients. We don't treat patients, by the way. That was a from me, a mistake. We don't have patients, we have subjects, we have participants. We have been helping our participants and deploying these guidelines since 2006. Bottom line, it's important to start early, use the tools available, be precise, and make it available to everybody. I'll take any questions if you have any. Thank you.
Dr. Molina, there are a few questions in the chat.
Okay.
First question is from Raj. So you already talked about EGFR when we were talking about kidney function. Additionally,
Yes.
he's also asking about protein leakage in urine.
Yes. So there's a difference between protein leakage in the urine and the GFR. GFR is a measurement of flow of filtration in the kidney. The albumin to creatinine to albumin ratio is actually a measurement of leaky glomerulus. So you can have a normal filtration and a leaky glomerulus. They're both independent factors. The problem is that if you have a leaky glomerulus, you have a sick glomerulus. And that sick glomerulus is going to end up having decreased filtration with time.
Okay. Carmen had asked about what about LP(a), but I think we talked enough about LP(a) later in the presentation. The next question is, what diet changes do you recommend to prevent the further plaque buildup? Also, is there a food that can help with plaque prevention?
Okay. So that's a really good question. And, there are multiple diets out there that claim to be associated with decreased cardiovascular disease. There was a beautiful paper that was published maybe 30, 40 years ago, which was the Lyon heart trial. So they took people who had had a prior heart attack and they separated them. And this is before the age of statins, by the way. They separated them to eat a low-fat, American Association low-fat diet, and to eat a rich Mediterranean diet. By the year 3, the difference in heart attack was 44% between those who were eating well and those who were having a low-fat diet. And the study had to be stopped at 3 years because it was thought to be unethical not to tell people follow Mediterranean style diet. So how is it that we can easily define a Mediterranean diet? Well, we can by saying, well, eat 2 fists of cooked vegetables per day, 1 fist of fruit, 12 nuts daily. And that actually almost meets all the criteria of the Mediterranean diet. And if you're not a vegetarian, then you have 2 servings of oily fish per week. Why the oily fish? Well, it's not because of oily fish and heart health. It's because the oily fish and sight health. Sight health, meaning if you make it to the age of 80 and 90, you just don't want to go blind. And macular degeneration is actually a very important cause of blindness as we get older. So if you eat one serving of oily fish per week, you have a 49% drop in the risk of macular degeneration as you age. So that's the story. And also oil. I mean, there's a lot of oil, oily fish, fish oils and all that, and they have been shown to enhance the effects of low dose statins, particularly in Japanese women. They have been shown to lower triglycerides if the triglycerides are elevated. They have very concentrated levels of omega-3s have in combination with statins have decreased the risk of further heart attacks by 10% in people with heart disease and stuff of that sort. So I hope that I answered that question. Now, what particular food to eat? I can't tell you. But if you go to Japan and you go to Okinawa, they say, well, eat bitter gourd. You go to an Ayurvedic doctor, he will say, or she will say, eat bitter gourd. So there you go.
Okay. The next question is from Aditya. If I work hard and lower my non-HDL cholesterol, then my ratio non-HDL to ApoB will suffer. This is not intuitive.
That's correct, but you see where will go lower will be your ApoB. So remember, there is one ApoB per non-HDL particle. You're just measuring you're measuring the concentration of cholesterol per particle. So not only do you lower the concentration, but you also lower the particle number if you live well.
Thank you.
If you live well, then you don't live well. I mean, if you're just going, just depends on. And now, how do you know that you're eating well? Because you know if you're eating well, if you're fully satisfied, and you actually, even before you start eating, you give thanks to the cook and to the nature that creates that food for you, because you know you're going to enjoy. So how is it that you can follow a good diet? You need to be a good cook or be connected to a good cook. And then everything is taken care of. You just need, you don't have to have, I mean, you don't need to be a good cook to work at McDonald's. The machine cooks it for you. Go ahead, please.
Okay, next from Ramesh. Can you ever stop taking statin? If yes, what decides it?
Well, you can take a statin if you find out that you don't need it. So how do you know if you don't need it? You can get a heart scan and your score is 0, you don't need it. Now, one thing is true too, is that statins have been tested in an age range. So that age range tends to end up at the age of 76. So people in their 40s to 76 have been included in these big studies. Those studies, for the most part, do not include 88-year-old people. So the question is, would a statin help me at the age of 88 if I haven't had any cardiac event? The answer is no. That's been studied. If you, by the age of 88 or 85, had not had a heart problem, taking a statin will probably not have an effect, because you may not have, I mean, there are other ways of, we all, and that could be many people will not just die of a heart attack, they will die of other things. So if you make it to 85 and no heart problems, everything is okay there, maybe then you should not be seeing a cardiologist. Maybe you can be seeing like an oncologist or some other type of doctor.
Another question for Carmen. Is there a tie between Lp(a) and high triglycerides?
Excuse me?
Is there a tie between Lp(a) and high triglycerides?
Okay.
Any
So
relation?
that's a very good question. And that is, there's a relationship between Lp(a) and diabetes and Lp(a) and metabolic syndrome. And we published this at the South Asian Heart Center. The greater the numbers of metabolic risk factors, the lower the Lp(a) tends to be. We don't know why, but the fact is that my opinion is that if you have significant factors that will predispose you to this metabolism, and you probably may not, and you have high LP little a, you probably will not be born. By that I mean is that high LP little a is a risk factor for infertility. So that's my opinion.
Okay.
But this has been reported and nobody knows what to do with it, that there's this inverse relationship.
Okay. Thank you, Dr. Molina. The next question is, can you address any correlation between these numbers, the cholesterol and all the numbers we talked about, and Alzheimer's disease?
Well, there is some correlation. There are some factors you could consider biomarkers, which, for example, ApoE isoforms, that identify individuals whose lipids are diet responsive. And they're meaning high saturated fat can increase the LDL cholesterol by 60% or more. And a low-fat diet can decrease the LDL by 60% or more. Those individuals are at increased risk of dementia. So the answer to your question is, I cannot connect one blood test level to dementia, but I can connect that this metabolism is associated with dementia. The more metabolic risk factors you have, like hypertension, low HDL, high triglycerides, high blood sugar, body mass index, they actually increase your risk of dementia. Alternatively, aerobic exercise can decrease your risk of dementia by 30 to 40%, much more than doing sort of newspaper puzzles, which have no effect on dementia.
Interesting. Raj asks, which factors can be reversed?
Well, we had talked about, well, what do you mean, what factors? What factors can be reversed? Well, if you have a
Risk
high
factors,
risk
probably.
factor, so you can actually, this is actually a very, very important question because it highlights some of the drivers of these abnormalities. The biggest driver for these abnormalities is weight. Until recently, we could not manage weight. We could not see what the effect of significant weight loss would do to these risk factors. But now we have the capacity to affect weight. And we see that people with diabetes, if they lose weight, or people with hypertension, if they lose weight, they stop having high blood pressure. They stop having diabetes. So yes, you can reverse diabetes. You can reverse hypertension. You can actually eliminate all your medicines to one that is helping you lose the weight. And we do this all the time now.
So can you reverse plaque formation?
Well, actually, that's another question. That's a good question too. So the initial lipid trial, which did not include statins. At that time, it was niacin, cholestyramine, cholestyramine. It was ilio bypass. The way the cardiologists were looking at this condition, they looked at it as plumbers. We don't do that anymore, but so people would have angiograms and we would actually look at reversal of stenosis. And a very vigorous drop in LDL cholesterol was associated with mild reversal of the narrowing, but it was mild, 7, 10, 15% reversal in the narrowing. But what you can do is actually stabilize the plaque. Now, plaque can be symptomatic if you have an acute inflammatory process that is narrowing the artery and giving you angina. If you decrease that inflammatory process or the inflammatory takes its course and it shrinks, then you may not lead with that. That narrowing may disappear. And the angina will disappear and the plaque will be smaller. Now, if you have a fixed fibrosed plaque, that's not going to change. But what you want to do is decrease the process of inflammation in the cap to prevent the cap from rupturing and giving you a heart attack. That we can do. And how do we do that? By living a low inflammatory lifestyle and also by taking medications that decrease inflammation. How do we know if we're having a pro-inflammatory lifestyle? We know because the foods we eat have a big label, and that label includes words that we can pronounce.
The same thing applied to calcium score?
The calcium score is not reversible. In fact, the calcium score will continue to progress. The problem is not the calcification. The problem is that the calcification represents that you have had inflammation. So it's not like, you hear about chelation therapy where you get EDTA to take the calcium out. That's not the problem. Now, chelation therapy sometimes is associated with less angina because the chelation therapy agent is a calcium entry blocker. So it's like taking diltiazem or amlodipine, like taking an anti-anginal medication. But this is not what the problem is. So you have to be careful. It's like you have to be careful not to do when you're studying statistics. So the standard deviation equation is this huge, but you can also do an equation this big and get the same result. Say, oh, let me just bypass. Oh, the calcium is that's why I need to take a statin, so can I lower the calcium? But that thinking does not apply here.
Well, thank you.
Thank you, Dr. Molina. Dr. Molina, there are still about 19 questions. I don't know how much time you have. What would you like to do?
Well, why don't we actually go for the next, let's do 5 to 10 more minutes and then we call it a day.
I'll be quick in asking the questions.
And I'll be quick in answering them.
The multiple people are asking, what is the value of risk assessment if most cardiac events occur in people with the intermediate risk, or intermediate risk should be called high risk?
Yeah. So actually,
Manners too.
That's a very, very good question. But that is a question when you're just thinking about the numbers and you're not looking at your life.
Yeah.
So the answer is the following.
Can I put any?
Excuse me?
No, somebody's microphone is off, Dr.
All right.
Molina.
Okay. So the fact is that when you look at why managing it? So what you're trying to do is what is your risk just walking in? And if you have what is called an intermediate risk factor, that means that your blood pressure is now going up. That means that your BMI is also going up. It just means that your HDL cholesterol may be low. So how is it that then why do you care about it if most of the heart attacks occur in that group and not in the high risk group? Is that if you're in the high risk group, you're already dysmetabolic. And what does that mean? Well, you're not only talking about heart disease, you're talking about having diabetes, having increased risk of cancer, because those high risk in the PREVENT trial, in that formula, also they increase your risk of cancer, increase your risk of diabetes, increase your risk of stroke. So you just have to take it from that holistic point of view and not just be what's my number? The issue here is, how well do I live? How strong do I feel? Am I smart and sharp? How many days of the week do I have brain fog? And how many days of the week I'm hitting the tennis ball in the sweet spot? Those are the important questions.
Okay.
In my opinion. I mean, just remember, some of it I make up. By the way, I didn't read it on a journal, but I'm just making this up, but it makes sense to me. So
Okay, there are multiple questions from Ajit. I'll read one at a time. What constitutes true statin resistance? If opting to take PCSK9, how is inflammation managed without statin therapy?
Well, you see, there's a difference between statin resistance and statin intolerance. Statin intolerance is when someone is taking a statin, they have a side effect, an untoward side effect to a statin. That can be muscle weakness, muscle pain, brain fog. you name it. I mean, it's just an allergic reaction can happen, a rash can happen, and you cannot take statins. That is statin intolerance. Statin resistance means that you are not able to reach a significant drop in the LDL cholesterol, but it's not assessed by the lack of anti-inflammation. It's just that the LDL does not get you to where you need to be. And then that's when the other agents are added to get you to what we have come up with is our our guideline goal, because people who are at those levels tend to have fewer events. And then even then, you still see that people are having heart attacks, because even then, you may still have inflammatory processes that are not affected consistently by a statin. So, if you're taking a statin, but you never go to the dentist and you never floss, and your mouth is full of bacteria in between, and you have gingivitis, you will still have an elevation in inflammation, and you still will have a risk of heart disease, even if you're taking a statin. So that's what we mean by that. It's unfortunately, it's not an engineering, it's not a math problem where you come with a formula and you get, it's not algebra, unfortunately, where you can predict.
Excuse me, a quick
Statistics.
question.
Yeah.
How do you differentiate the chest pain from GERD to the cardiac origin pain?
Well, it's sometimes very difficult. That's what we call sometimes pain from GERD, heartburn. It's difficult but therefore you need to be fully evaluated. Sometimes you can do it by history. Well, tell me about your pain. Well, I get pain after I eat a lot of chilies and ketchup, and I take some Tums and it goes away. That's probably GERD. I get this discomfort when I'm going up that hill and I stop, it goes away. It's probably coronary artery insufficiency. Sometimes you can go up that hill and get the discomfort because the acid is splashing up, and then you don't know. You have a stress test.
Okay, thank you.
You're welcome.
Next question from same person is, with comorbidities specific to South Asians of BMI and obesity at lower weight than general population, how does GLP-1 support dyslipidemia management and ASCVD management?
So the question is, since Asians, not only South Asians, but Asians tend to have these metabolic derangements at a lower weight, a lower BMI, we then shift to the diagnosis of overweight and the diagnosis of obesity. And we would then use the GLP-1 agonist to try to treat obesity. So for someone who's not Asian or South Asian, a BMI of 26 is overweight. For a South Asian, a BMI of 27 is obesity. So then you're treating obesity with metabolic derangements. So that's how you use the GLP-1 agonist. If you have fatty liver and you have a normal BMI, but you still have fatty liver, the fatty liver will respond to weight loss. Why? Because when you're losing weight, the first fat that goes is the fat in the viscera in the liver. So you can treat with a GLP-1 agonist, and you will help treat the fatty liver. So there has to be, we come up with these numbers. What is a normal BMI 23 or less? Why BMI 23 or less? Why? Because in some studies have been shown that you start seeing higher blood sugars with BMI over 23. But not everybody. For example, only 50% of South Asians who are obese are metabolically deranged. The other 50% are normal. So you just have to sort of, it's not just, it's a multifactorial process, not just a one number process.
Anita,
Okay.
would you end up in 7:20? It's 2 more minutes, so
Okay. The last question, what causes inflammation?
Okay. So the inflammatory response that we have been discussing here is an arterial inflammatory response. Now, that may be different for rheumatoid arthritis. That may be different for gout arthritis. That may be different for how you deal with a sunburn. And that may be different how you're dealing with acid in your esophagus, with burning your esophagus. But in the arterial circulation, the process begins with deposition of cholesterol, the movement of macrophages that actually then gobble up the cholesterol and become what we call foam cells, are full of cholesterol that they can digest. And these foam cells start putting out all kinds of terrible things that are just causing more and more inflammation and calling for more polymorphonuclear cells that then become foam cells. And then they put out interleukin that then go out and recruit more cells. So that is what's happening in the arterial circulation. When you actually have gout, you have deposition of crystals. This deposition of crystals are then gobbled up by polymorphonuclear cells that then become activated because they cannot digest the uric acid crystal. And then the whole cascade starts not because of cholesterol that is not digestible, but because of uric acid crystals that are non-digestible within that polymorphonuclear cell. So there are different types depending on where the inflammation is.
Thank you, Dr. Molina, for patiently answering questions until 7:20.
You're welcome.
Ashish.
So thank you, Dr. Molina, and thank you everyone for being here today. I know that these guidelines have come out and will continue to cause a lot of questions, in the coming months, until, we get to some semblance of kind of what is God's staying power. But it's a step in the right direction. It does acknowledge all the markers that we have been looking at and the ABC risk profile that we've actually created at the South Asian Heart Center to comprehensively evaluate individuals. So thank you, Dr. Molina, for tackling this hard subject and kind of making it easy for a lot of people to understand what's going on, really. It's not an easy task, but you make it sound very, very simple. So thank you for that. I've really enjoyed the presentation today. We will have this recording. As a matter of fact, I will take it upon myself to send a link to everybody who is part of this group. As soon as the link is up, please help us by forwarding that link over to people that you know who might benefit from kind of the discussion that happened here today. So with that, I'd like to end. Thank you so much. Thank you, Anita, for being a gate huddle moderator. I know that we didn't address all of the questions, but the questions are endless. They happen. You can shoot them off and we can kind of, try to answer as well. Our email address, I'm going to just send that over to everybody just so that you have a way to access us easily. sahc@elcaminohealth.org.
So, I just want to sort of one factor here, and that is statins do not help people who are not at risk. Okay, so that's really, really important. And that's where you have conflicting data, because if you are not at risk, the statins can only hurt you because you're not going to have any of the benefits because there's no benefit to be gained. So this is really important, that we just don't think in a yes, no kind of phenomenon. We also have to say, well, yes, if there's a risk, and no, if there's no risk. I'm just answering one of the questions on the I just couldn't help myself. But thank you.
Thank you.
All right then. Bye-bye.
Bye.
Bye.